Good morning, everyone. Thank you. It's great to be with all of you as we embark upon a really important dialogue, and we'll leave ample time to have you join in and ask questions as well. But I am joined by an extraordinary panel of creative and innovative leaders in this space. So joining me are Dr. Sachin Jain, who is the president and CEO of CareMore Health, Dr. Jeremy Nobel, who is the founder of the UnLonely Project, Dr. Lynn Goldman, who is the Michael and Lori Milken Dean of the Milken Institute School of Public Health at George Washington University, and my colleague, Dr. Anand Parekh, Chief Medical Advisor with the Bipartisan Policy Committee. And together in dialogue, we'll explore the growing topic, the field of both loneliness and social isolation, with particular emphasis on the negative health impacts and what we might be doing to solve this problem. But before we dive in, talking with members of the panel, we decided it would be important to define some terms up front. And that is that loneliness and social isolation are in fact related, but there are really important differences. So we'd want you to think about loneliness as subjective. It's how you or I feel about our own situation, whether or not we have the company, the companionship, connections we need to thrive and be resilient. And social isolation is related to more objective criteria. So you might think of it as the size of your social network, the frequency and quality of contact with it, whether you're able to access important social supports and resources in your community as well. Both are pernicious, right, panelists, and increase negative health outcomes, including increased risk for heart disease, for depression, for early cognitive decline, and in fact for death. AARP relaunched a survey recently, and it confirmed that about 1 in 3 older adults report that they in fact are lonely. It confirmed that as it relates to loneliness and isolation, this was a study of adults 45 and older, as it relates to loneliness and isolation, low-income individuals and those from marginalized population groups, in particular LGBTQ older adults, are at significantly greater risk for loneliness and isolation. So that we have to address this issue. In fact, AARP published a study this year that was able to show that social isolation increases Medicare spending by about $7 billion annually. So it is well past time that we address the increase of loneliness and isolation as public health concerns, and that we get at figuring out interventions or innovations or interventions that in fact can be successful. Now, let's talk today also about technology, which is key. I know we're exploring, many of my colleagues, the use of technology, whether it's voice-activated technologies in the home to increase connection, whether it's ride-hailing apps to improve the ability for individuals across the age spectrum to get to their appointments and social connections. But remember that connection matters. I think my colleagues will agree there is no substitute for the human factor here, which is sometimes the messier part as well. So let's begin, colleagues, and we're going to mix it up. Lynn, I want to start with you. When I think about your work as dean and you think about the context of public health, is the rise of loneliness and isolation a public health epidemic? How would you look at it?
So I think that's a really interesting question, and I should start by making sure everybody knows I'm a pediatrician, so a lot of my focus is on the earlier stages of life, but I think that this is an issue that is really an issue across all life stages.
It absolutely is.
And I think we have a lot of evidence that in terms of longitudinal studies, that those who have fewer social connections and feel more lonely and when they're younger, then proceed through life at more and more risk of even having more social isolation and more loneliness. But is it an epidemic is a very difficult question to answer. And one thing that I realized in prepping for this meeting is that, like some of the drugs that we hear about, we've known about this problem as a major public health risk for a very long time. It was back in the 1970s, and some of my professors were doing some of the original work, Dr. Len Syme, Dr. Lisa Berkman,
right,
who, illustrating how important these factors are to health. And like with some drugs, where there are many decades sometimes between the discovery and doing something about it. You know, I think that we're at a point now where we're actually ready to do something about it, even though this isn't a problem we've identified intellectually over a very long period of time. But isn't an epidemic? Well, we don't have great longitudinal statistics. You know, the national statistics that have been created by the CDC have been done very sporadically and not consistently. And so I would love to be able to show you the trends for loneliness like we can see for the trends for people with obesity, because I think it's incredibly important to understand whether we're doing better or doing worse, and we need to do that. However, that kind of data have not been generated, and so you have data across many, many studies that are not strictly comparable. Yes. And also, another way that we might think of an epidemic, is it very prevalent in a way that it's having a major impact on health? That's how the public often thinks about the word epidemic. In that sense, yes, it is. Because the data that we do have indicates that whether we're talking about loneliness or we're talking about social isolation, that it's very prevalent, that we're talking about anywhere at different ages in different populations between 1 in 5 and 1 in 10 people. That's an amazingly high rate. And so I think that from that standpoint, it's a compelling public health issue. I think that you pointed out the connectivity to highly serious medical problems, whether it's mental health problems, and we know that many of these mental health problems are becoming more pervasive and becoming worse, whether it's substance abuse, the rates of suicide, untreated mental illness in our population, but also very serious diseases like cardiovascular diseases, yes, which were some of the earliest to be identified as having this as a risk factor. That's important. We go through incredible efforts to get people to reduce smoking and other risk factors for cardiovascular disease, yet loneliness is on par with some of those risk factors, just hasn't been identified in the way that we can identify a substance. Yep. And so if we thought of it as a substance, I think we would have been doing something about it more concretely a very, very long time ago. And the last thing I want to say is that in terms of it being an epidemic, the pediatric literature is quite alarming from a couple of perspectives. And one is that what we see as the continued, if you may, breakdown of the way that we used to have social networks for children, which was, you know, we used to have these multi-generation families and households. Sure. Then we kind of had the nuclear family. More and more and more now, we have a one-parent household. And so fewer and fewer social connections for children in their family. The grandparents, the aunts and uncles are all far, far away, maybe seeing them a couple of times a year, right? Social media. And, you know, I personally have witnessed, I mean, as a pediatrician, I am trained to make eye contact with children, to connect with children, to befriend them. That's one of our little MOs. That's a strategy, you know, before you give them a shot. And should continue
across the lifespan.
If you don't know, well, if you don't know how to do that, if you don't know how to do that, you can't do a physical exam. They will scream. And so you learn how to do that, right? And I do that all the time. But what I see more and more, if you're riding on public transportation, you're on the metro, the child is not making eye contact with you. The child has a little tablet right in front of their face. Sometimes the child is sitting there with their tablet and daddy or mom has their tablet.
No, Lynn,
and they're both staring at tablets. They're not interacting with the people on the metro. They're not interacting with each other. They're interacting with the device. Now, that could be a good thing. It could be a pathway to making connectivity. But I would argue that the inability at an early age to begin to form eye contact and learn about social smiling and social, this is basic for our development as human beings. And so I think we have a lot to be concerned about in terms of the next generation coming forward and how they are learning how to connect.
You know, Lynn, you're raising such important points, which is the time is upon us. It may, in fact, be getting worse, and what are we going to do about it? And as Lynn said, I mean, I often quote, I think all of us do, the study that found that prolonged isolation and loneliness are the health equivalent of smoking 15 cigarettes a day. So we probably don't need to say more about it. Now, Sachin, you've been on my mind because you are a key leader in this space and really looking at it from a healthcare company perspective. And I shared with you earlier when I was in London about 10 days ago talking about this issue. They have the Minister of Loneliness, the Campaign to End Loneliness, and you have a Chief Togetherness Office. I'd love for you to share with us the why of that, the human case and the business case. What's happening at CareMore?
So first of all, Chief Togetherness Officer is way better branding than Minister of Loneliness.
I love the Chief Togetherness Officer title.
Britain went live with this Minister of Loneliness,
right?
and we said Chief Togetherness Officer. and who can argue with togetherness, right? It's, loneliness is a disease, from our perspective, that's as old as the human race. We, as humans, have a deep personal need to connect with one another. And when we don't, we feel it. We feel it in different ways, and it shows up in the form of chronic disease. It shows up in the form of mental illness and depression. And one of the amazing things about this field is that it doesn't require a new drug. It doesn't require a new device to be invented. It doesn't require a new procedure to be pioneered. It doesn't require a randomized controlled clinical trial, right? It really just requires that we be our best selves, that we be human. And I think there's an incredible role for the health system in actually creating more and more connection. I don't love the social determinants space in general because I think there's a tendency to make everything the domain of the healthcare industry. And we all know that the healthcare industry doesn't do a good job with lots of things. But I think one of the great things that we can do is be the front door for connections to others. So we will do things like write prescriptions for engagement with one of our togetherness connectors, or participation in one of our senior fitness classes in the gyms that we operate alongside our clinics. And those types of things make an incredible difference when you actually pair them with things like transportation to actually bring patients to and from places where they can actually interact with others. We've done things like reorienting our physical plan. We've changed the waiting room to actually be a community center. When you think about 300 or 500 square feet, that right now, the traditional waiting room is structured a lot like this audience. It's people looking in one direction, not looking at each other. And so we've done things like bought puzzles to have people work on together. So, when you're waiting for, an hour and a half for your appointment, it's usually not that long. But everyone's had that experience. Everyone's had that experience. There's an opportunity for you to actually use that time to make a connection with someone else. And so I think there's an incredible opportunity for us without spending an extra dime, right? That's the key thing about this. Without really spending a dime, to actually pull a lot of cost out of the healthcare system by refocusing and reorienting our role as one of actually creating social connection.
Yeah, I think that's terrific. But even if we do spend some dimes,
and
it's worth it when we think about the human aspect, right? And also about the ability for individuals to be resilient and healthier across their longer lives when we think about longevity.
For sure, and the reality is we actually are doing this in part because we think we can actually save healthcare costs.
Right.
So we're a Medicare Advantage provider entity, and so we're fully delegated all of the medical costs for the patients that we take care of. And so that has created incentive for us to think about ways where we can actually engage our patients. And the ones we focus on the most are the ones that we see the least. That's how we think about our job, is if we're not seeing these folks, that means that they are developing chronic diseases that we could intervene upon early and prevent the long-term complications of. And so that's a big part of the business case. I mean, we are a for-profit division of Anthem, and our business case here is very clear. We think that we can spend to save long-term healthcare costs for our members.
But it's really shared value, too,
That's right.
because it's social good.
For sure.
That you're focused on as much as you're focused on the
Absolutely.
good, meeting the objectives of your business.
Absolutely.
You've raised a lot of points that are important, I think, Anand, for you to jump in on. I want you to think about it in terms of your work at the Bipartisan Policy Center, which you might speak about loneliness and that work today as well, but also the leadership role you're taking on helping us think through rural versus urban versus suburban and maybe different needs and policy around even built environment, which Sachin addressed.
Thanks, Lisa. An honest assessment from me is that in my former lives as a physician first and then a public servant at Health and Human Services, If you asked me then, what are you doing about loneliness and social isolation, either for your individual patient or looking at the population at large, I'd have to honestly say that I wouldn't have known what to say. And so this has, for me, been, over the last couple of years, really a learning process. This has been a new area. And I think at the Bipartisan Policy Center, we have taken a slice of this issue by focusing on some vulnerable populations here. One, rural Americans, and two, older adults. So certainly in terms of rural and urban, their social isolation and loneliness are prevalent amongst both populations. But of course, for rural Americans where access to healthcare services, access to other social services are more difficult, these issues are highly prevalent. Rural Americans also have a higher burden of illness. And then when you think about older adults and limitations of cognition, mobility, hearing, vision, loss of a spouse, for example. So these are two populations, if you will, that we thought were more vulnerable. And we did some work over the last couple of months along with Tivity Health, which is a health and wellness company, and the CEO is Donato Tramato, who's really a visionary. And we brought a group of stakeholders together and came up with a set of 4 actions that we think could move this field forward from a policy perspective. And I'll just run through them. I'm sure that we'll get to discuss them more in depth. The first, I think, has already been touched on here. We need to increase national awareness about this issue, social isolation and loneliness, in a way that hasn't been done before. We need to be talking about it in all circles, whether it's media, whether it's public servants. We need to educate healthcare professionals, public health professionals. We need to reduce the stigma there might be out there for issues related to social isolation and loneliness. Second, we need to leverage existing infrastructure and investments in this country and communities across the country. Today, we have community health centers, we have local public health departments, we have area agencies on aging, we have YMCAs, we have Meals on Wheels going into homes. We need to leverage those investments to connect individuals, particularly seniors and other vulnerable Americans, to the services they need so they're less isolated. Third, we need some public policy solutions here, and I would look to the federal government. Lynn mentioned that we don't quite have the data to know whether this is an epidemic. I can tell you there's probably not a line item in the CDC budget or the NIH budget or the SAMHSA budget connecting this to diseases of despair. We need the research and the data to guide us if indeed this is a public health challenge. And certainly from a technology perspective, we can be more connected, but that doesn't mean that we're going to be less socially isolated or less lonely. But technology is important, and we need broadband and a lot of tools to ensure that's there.
Hear, hear.
And then the fourth really action step, and Sachin is a real leader with CareMore in this, we need to make sure, to the extent that the healthcare sector can do something about this public health challenge, that it does. And that includes ensuring that we have the right screening tools, we have the right quality metrics, and we have the right delivery models so that healthcare entities can address this problem, which will improve their beneficiaries' health and reduce preventable healthcare costs. So those are just four action steps from the Bipartisan Policy Center perspective. Again, coming to this as an organization, perhaps later than others, and myself as an individual personally coming to this later than others. But I think this is a challenge. It's here and it's real. And it's not something that we just sort of put on the side. We really need to address it head on.
Yeah, Anand, you brought up so many important topics, and later let's talk about, our study also actually, it did prove out what you're saying about access in rural areas, but it also indicated that in urban areas, individuals can be lonelier because of urbanicity. Your own expectation that you'll know your neighbors, and then in fact how let down you are when you don't. So thank you. Now, I want to turn to Jeremy Nobel, my friend and colleague, who is a leader in public health, a physician, a faculty member, and also a poet. So I want you to bring all of yourself to the conversation, Jeremy, as you always do. And I'd love for you to talk about why the UnLonely project, but also talk about where you see risk factors across the age span, because you're doing some really interesting work across the health span and lifespan. And how does creativity play a role in helping us build interventions?
Right. Well, a great set of places to jump off. Maybe I'll start with, why is loneliness so topical right now? It really has kind of swept forward, maybe ahead of any formal epidemiologic analysis to show that it really is an epidemic. And I think it's the growing awareness that loneliness won't just make you miserable, but it will kill you.
That's
and
right.
as a social determinant, it's actually very interesting, because you think of the other social determinants, it's the one I think that the greatest majority of people can relate to, like relate to personally, right? So you think about housing insecurity, food insecurity, job insecurity. I would hazard to say most of the people in this audience and people you love and care about are not as confronted by those social determinants of health as being lonely or disconnected. Right. So it actually is kind of the universal social determinant of health that I think has kind of as a subtext accelerated the conversation around it and given us a bit of a vocabulary, as Anand said, to begin to articulate it in some powerful ways.
It's really relatable. You're absolutely right.
Right, and so we're going to begin actually kind of relating a little bit to the audience. We're going to make this personal. Show of hands time, okay? But I'm not going to ask who in the audience is lonely. We know it's about 40 to 50% of you, not 2 in 10, but 4 in 10, right?
I want to stop there for a minute. That's what's so tough about engaging individuals in interventions, isn't it? Because it's what you talked about, chief togetherness officer rather than chief loneliness officer. Because people don't raise their hand and say, I'm in, I'm lonely.
Right, so here's the question.
Right?
I'm not going to ask you to raise your hands if you're lonely. I'm going to ask you to raise your hands if you were lonely, would you find it awkward to talk about it? Right, so that's all the hands, including ours. So you think about what we're trying to do about loneliness. Well, obviously we have to increase awareness. If we do believe, it has the increased risk of early mortality of 15 cigarettes a day, an odds ratio of 1.3, that is what smoking is. Totally separate from it being the single biggest preventable risk factor for major mental illness like depression, general anxiety disorder, substance abuse, many conversations going on at the Milken Institute around that, and suicide. Right? So we can do something about it, but not if we're unaware of it, and not if we're not willing to have conversations about it. So I started the UnLonely Project, a 501c3 nonprofit, about 3 years ago after having several conversations with folks, including Sachin, about what's going on in our society. And we talked about some kind of remarkable work by Bob Putnam, Bowling Alone. It's not a new idea, as Lynn said, that we're a lonely society. I think the US society may be leading in loneliness characteristics because it's kind of the flip side of some of what we've celebrated for centuries. I can get it done, I can do it on my own. Well, very little gets done on our own, but it is part of our popular mythology. So it's kind of led to bowling alone. The only problem with that is it will kill you to bowl alone, or it'll kill you at least faster than kind of other things will. So what do you do about it? So the UnLonely Project has 3 goals. Very aligned, actually, with the Bipartisan. In fact, you probably read our mission statement somewhere along the way, and I'm glad that they're aligned. So first is to create awareness. Right? So just the fact that this is on the agenda here, that so many serious organizations are putting it high in their agenda just to discuss, is novel and groundbreaking and important. The second thing, and it comes back to the show of hands exercise, is the stigma about loneliness is as high as anything I've ever encountered in public health. So I've done public health campaigns for several decades. Let's take seatbelts. That's actually, getting people to wear seatbelts is a major success story in public health. When the first seatbelts came out, you had to pay extra to have one in your car. This was in the early 60s. And if you think about it, it was actually a constellation of activities: awareness, regulation, click it or ticket laws, all this stuff. And now, the majority of people do wear their seatbelt, and it has a positive impact. Now, there was a lot of behavior change effort required for seatbelt campaign, but there wasn't stigma. People didn't want to ignore that message. Right? Now, the closest it comes is the general urgent campaign to destigmatize mental health, and it's related to that. I think we actually can learn a lot from what's been successful on things like awareness about depression, other mental illness factors, and build on that. So our second goal is stigma. The third, and I think that's probably where we're all focused, is how do you develop effective programs and reduce the risk? Because there's no question there's risk. And not just programs, but ones that meet 3 criteria: effectiveness, scalability, and sustainability.
Right.
And so at the UnLonely, we're exploring that. There have to be primary business models driving it forward. Sachin touched on some of them. If you're a Medicare Advantage plan and you own total cost of care, investing in simple, highly engaging programs that get people more activated in their care, increase medication adherence, is going to keep them out of the emergency department and reduce total hospital bed days per 1,000. In the margin created from that resource saving, you can buy a lot of intervention programs for loneliness.
Right.
So maybe I'll stop there for now.
I don't want you to stop just yet.
Okay.
You're on a roll.
All right.
And others will jump in. But let's talk about, and I would like all the panelists to jump in. You and I frequently discuss the fact that it's a myth. We take it for granted, well, you're old, you should be lonely and disconnected. We know that isn't true, right? We need purpose and connections across our lifespan. But what about the rise of this? Lynn talked about it among children and young adults. What are you seeing, for example, on college campuses?
Right, so the UnLonely Project, we're still relatively small, so we've identified particular populations at risk. Public Health 101, I did, kind of go to where the biggest urgency is. So older adults and caregivers for sure. The workplace, not because work per se, although some workplaces do foster a sense of isolation, but people bring their loneliness to work.
That's right.
Right? Because that's where we go. So if you're LGBT and feeling alienated, if you've got a major medical condition, if you're disabled, if you're a veteran struggling with kind of reemergence into society, you bring it to work. So it comes back to the sustainable business model. If you're an employer, you want your employees to be able to make eye contact. In fact, I won't name the employer, but I've spent time, we're doing a lot with employers, a large high-tech firm, part of the FANG group, I won't say which letter.
Well, now you're making us really curious.
Right, and they actually, in their new employees, particularly the male engineers, they actually give them how to make eye contact lessons. Lessons. Because you can't collaborate and connect with other people without making eye contact.
Well, it has value in their business model.
And it has value in the business model.
Right.
The third is colleges. So suicide, substance abuse, and depression rates have gone up about 35% in colleges across the country in just the last 5 years. If you do the math on where that curve goes,
there's work to be done.
It's a really worrisome story.
Yes.
So what can we do about it? And I think that's obviously we're all kind of thinking about that. What we do in the UnLonely Project is actually very simple. It does go to creativity, as Lisa mentioned. It's actually encouraging people to tell their story as an authentic way to share something about themselves that'll allow them to be seen and visible to someone else. And we use creative arts as a catalyst. It's not magic. It's not like take 2 poems, be UnLonely, right? But it does allow us to give voice to something that's often hard to describe.
Yeah. And in a group, and it draws
and in a group, and then you're connected because of active listening. Someone shares back, and we found those to be very effective. We think they're scalable using both digital and face-to-face models.
Right. Sachin, I want to jump to you, and then I know Lynn wants to jump in as well. So I want to get to the measurement. And you also brought up in your opening remarks the idea of social prescriptions, which I think holds great promise. So there are all sorts of tools. The UCLA loneliness scale, which is easy. We use the Duke Social Support Index. But what are you doing for screening across healthcare clinicians? And in addition to social calls, can you talk more about any measurements you use to address the effectiveness or ineffectiveness of interventions?
So we enroll patients in 3 different ways into our programs. Every CareMore patient goes through what's called a Healthy Start visit. It's an annual wellness visit. And we've, for years, actually incorporated questions about social connectedness and social isolation. And so we actually, before we even got started on this journey, we had a database of 2,000 people who had identified themselves as feeling socially isolated or lonely. So we already collect that information in every single annual wellness visit that we do. The
screening's embedded across all that you do.
Exactly. Okay. The second thing that we did is when we created this program, we actually sent a letter to every single one of our members, and we said, tell us about yourself if you're interested in getting involved in this togetherness program to create more connection with others in your community. And we had about 500 people say, yes, I'm interested in this, right? So we found another 500 people who self-identified themselves. And then the third thing that we do is we actually ask healthcare professionals to refer patients. So when we call it an epidemic, we actually call it an epidemic in plain sight. When you meet somebody who is lonely or socially isolated, you see things. You see that they usually come to their appointments alone. They're usually a bit disheveled. They're usually not totally when they speak about their lack of connection. Sometimes their main point of connection is actually coming to the medical office for visits. And so there are things that we train our clinicians to look for to help identify whether patients may be at risk for loneliness, and obviously you'll still miss some. And the last thing that we've started to do is actually look at our data and to try to find individuals who have a high burden of chronic disease, but who aren't necessarily engaged in their care, because we think non-engagement is also another risk factor for loneliness. So that's how we find folks. And then I forget the second part of your question.
No, you talked about it. You addressed it, because it's both how you find them, but also then how you measure the effectiveness of intervention. Some of that's level of engagement, I would imagine.
Well, so the effectiveness is really around level of engagement. So we look at participation in our programs, participation in our preventative health screenings, and then we actually look at clinical outcomes, like admission rates to the hospital or bed days per thousand.
Right.
What we're finding, and it's early, and I want to be very careful about stating these results. What we're finding is definitely much higher levels of engagement. So, we've seen 75% increases against a control group in terms of engagement. And then we've seen lower overall healthcare costs.
Yeah.
And again, there's some work that we need to do to validate some of that, just because it's hard to create, real natural control groups in this space. But it is something that we're very optimistic about.
And it's so
we are
important.
scaling beyond CareMore to serve all of Anthem's Medicare patients.
Yes, I think that's so important. You're dealing with such a vulnerable population. But the measurement piece is thorny, but really important, right? Because there's a tendency for all of us to find a shiny solution in search of a problem. It's so important for us to be thinking about the root causes as it relates to loneliness and isolation, and to have effective solutions as well. Anand and Lynn, will you jump in as well on this conversation about measurement and also about social determinants of health? I think you moderated a panel here about that, but that's everybody's business, not just healthcare, addressing social determinants.
Yeah, I think on metrics, the screening tool is critical. Quality metrics are critical here. So developing, endorsing, and then adopting quality metrics, they're validated. That could be very helpful, could be a nice signal. In value-based healthcare transformation, we talk about this all the time, it's happening in healthcare, but the currency are metrics. And if we can get the metrics right here, perhaps that could be a way to drive healthcare. So I think getting the screening tool right and getting the metrics right, I think is really important. Social determinants of health, I think at the end of the day, even though studies show sort of independent relationships between social isolation and loneliness with mortality, I think there is a really important intermediary factor here, which are the important determinants. Why are people lonely? Why are people socially isolated? And could factors such as housing, nutrition, transportation, could these factors be important points to focus on to alleviate social isolation and loneliness? So I do think, Lisa, that social determinants of health play a critical role. I think there are solutions within the healthcare system, as we've been talking about here, but perhaps more importantly, the solutions are going to be outside the four walls of the clinical system. And the solutions there are linking individuals who are vulnerable to the important social services they need. And that's where the social determinants of health comes in. So
I want to tell you a personal story just real quick to build off of that, which is really related to my parents who are aging, getting into their early 70s. And I would make visits back to see them in New Jersey, and I would talk to my dad, and he would say, I'm less interested in seeing people. I'm like, oh, have you heard? I would ask him about his friends, and he'd say, I'm not interested in that anymore. And then two things happened that changed it, and it was actually pretty dramatic. One is he had his cataract surgery, right? And then all of a sudden he was able to actually see better when he was driving, and then he was more interested in actually seeing his friends.
And going out.
And going out and seeing others. And then the second thing is we introduced him to Uber, and before long, he was back seeing people, and it was much easier for him. And so, when you talk about kind of the underlying factors, very few people would actually connect cataracts or hearing to social connection and loneliness. But the reality is that
major risk factors.
There's huge risk factors, because if you can't hear, if you're having these uncomfortable social interactions where you can't hear people, then you can't necessarily connect with them. And so you start to retreat, you start to withdraw. And, social connection is, something that builds on itself, right? And so if you don't have it, then it just starts to go away.
The loss of it, it really deteriorates all health. And Anand, as you said, we also should address the determinants, not in silos, but really together, and then thinking about connection as core to all the solutions. Lynn, you've been so patient.
I'm fine. I mean, what I'm hearing, and kind of putting this in a public health framework, that we think about primary prevention, doing things that prevent people from developing a problem in the first place, in this case, loneliness. And I think some of these environmental interventions that people are talking about, community-wide interventions, are so critical in terms of that. But we also talk about secondary prevention, identifying people through screening and other tools, maybe don't realize that they're lonely. They haven't yet manifested any of the adverse consequences, but they're on the path.
Yes.
And then I think we have people who already have toxic levels of loneliness, and they're already sick, and that they, and they're probably sick enough that even a doctor can identify it right in the doctor's office, right? And so I think that, and we need to be acting on all three of those levels. One of the things that I think is, two things I think are important to recognize, and one is that we really haven't done a lot of the science around interventions that needs to be done. And I think somebody mentioned earlier that there really isn't any part of the government that thinks it's their job to do this. So what are the trials? Where has been the evidence generated to test interventions, gather the data? And the metrics are key to that. You have to have the metrics. We need to make sure that the metrics are culturally appropriate across all of our populations, because there are huge differences in the way that behaviors are taught, through a life course in different cultures, and this is very difficult. But I think that loneliness can be a part of what we call not just epidemics of loneliness, but also syndemics, that other things that are also harmful to health are going to be associated with loneliness. And I'll give you one example, and that is that many people have obesity, and that a child with obesity is going to be subjected to stigma, which may then cause loneliness.
Yeah, and social isolation.
And social isolation. And so, and I would also say drug addiction is such a thing, opiate addiction. And so people who have other risk factors, multiple risk factors, syndemics, are at the most peril in terms of being in harm's way. And that we need to be able to take that into consideration and not say, okay, this is all about being obese, or this is all about addiction. Understand there's a component of social isolation, a component of loneliness, and many of these other issues that we identify as risk factors.
Yeah, it's and sort of the intersectionality of identity as well, as you're saying. So very, very important when we think of interventions. Jeremy, jump in.
Yeah,
and a question for
I'm
all.
eager, and at some point, obviously, we'll go to the audience. But
soon.
One thing I wanted to emphasize is we need measurement for sure, but we also need a model, right? So what's really going on in the population and so on. So the model we've kind of come up with, and it's public health 101, as we call it, the pyramid of vulnerability, right? So imagine a pyramid, and imagine the base, and there are only 3 slices, right? So the base slice is everyone at risk for loneliness, right? So who is that?
Everyone.
Everyone.
Good. All right. So that's everybody. But then the middle slice, and there are things we can do, and the reason the model's important is the intervention's different at different slices. So bottom slice, everybody, right? So we don't want to pathologize or medicalize loneliness. We want to humanize it. So let's think about how we humanize it for the base of the pyramid. And even asking people how they're feeling is humanizing it at the base of the pyramid. But then there's that very important middle tier. And so that's when someone has a precipitating event. It can be obesity. It can be loss of a spouse.
Mobility impairment.
It could be mobility impairment. We could actually develop a matrix, and we're developing this, of what are these precipitating factors. We can screen for those, and not just in the doctor's office, but in schools, in workplaces, and in non-medicalized ways, offer support to the middle tier and invite people to engage, interact, not just with other people, but with themselves on the negative emotions of guilt and shame, which is basically what holds people back from connecting. And then, as Lynn mentioned, you have the tip of the pyramid, These are people who have been so devastated in a way by isolation.
Multiple
that they
factors.
Have multiple factors, suicidal ideation. They're already in a substance abuse scenario. They've already stopped taking all their medications. For those of you who follow longevity in the US, you may have seen the disappointing news in last December that for the second year in a row, life expectancy in the US did what? Went down. And it went down driven by so-called deaths of despair, which are caused by diseases of despair in very specific cohorts. And a lot of that is not just the cardiovascular risk of despair, which we know is pro-inflammatory, but that you withdraw from the care environment. You withdraw from self-care.
It's the hopelessness of care.
And with that, you're not screened for diabetes, you're not screened for colorectal cancer and so on. So you die younger, right? So I think that's all part of it. So I think as we think about what we can do about it, it has to be multi-stakeholder. We can't say, oh, delivery system, fix it, or work with health plans. You know, we have to work with employers, schools, pharmaceutical manufacturers, suppliers, and also groups that we don't traditionally think of as health stakeholders like retailers.
Right.
One thesis that we've been working on in partnership with the American Red Cross is this idea that volunteerism can actually be a treatment for loneliness. And so we're working with the LA chapter to really try to create a program where people will learn how to volunteer and then in the process actually meet other volunteers and get connected to others in their community and then make a difference. And a lot of loneliness is also I think driven by a loss of self-worth. And so you have to kind of really address that part of it because I think that's just as critical as anything.
I think you do. And in fact, volunteerism, the research is in. Weekly volunteers have a 16% higher chance of being happy. So that's a real win. Happier, healthier, and helping us solve entrenched social problems.
That's right.
So I think that's a real win.
I'll just add very briefly that I think we also need cross-generational approaches.
Yes.
Right? We need young people to spend a little less time on their phone and talk to older. It sounds simplistic, but to older.
Call your grandmother.
And sort of bi-directional approaches, because that's where we can increase, social cohesion in this country.
I think you're right, and we all could do better, right? So at AARP Foundation, we celebrated Good Neighbor Day this year, which is already on our calendars, with the notion that, and it's been said by the panelists, each of us could do a better job of being on the lookout for our neighbors, looking for signs and engaging intentionally and purposefully with others. We're going to feel better in the long run as a result. So before we go to the audience, we've talked a lot about the importance at the entire summit here about cross-sector strategic partnerships as really being important for replication of interventions and for scale and sustainability. So can anyone jump in and give an example of what you think is a cross-sector partnership that's working in the space of increasing connection for individuals? Anyone?
Well,
it's an area where we need work.
Okay, hand in the audience.
Jump in.
My name is Jake. I'm with Lyft, actually.
Hi, Jake. We work with Lyft, as you know, on a research project. Right.
So working with CareMore as well, and many others. And
yes.
I'm glad you brought up the sort of double-edged sword of technology, that it's in many respects making us farther apart from each other, but can also be a tool to help solve problems like loneliness, can also address access to healthcare via transportation needs and things like that. One of the challenges that we've noticed, whether it's ride sharing or other technological advancements that can help in this space, is that when you're looking, and this is particularly when it comes to seniors, that's the toughest nut to crack when it comes to making them feel comfortable with new technology and adopting new technology. So I think, whether it's the pilot and work we're doing with AARP to just get ride credits to seniors and not saying you need to do X with it, you need to go to the grocery store, you need to go to the doctor, but just say, use these for whatever you want, and noticing some really great early data that's showing that it's improving their health and well-being just across the board.
Yes.
Or whether it's working with Robin on your team, your CTO, and figuring out how we can best crack the nut there. But how do we get them to actually use it is something that we've been struggling with and would love to hear.
The digital divide is very real. We were 3 years ago, we were the first Medicare Advantage organization in the country to partner with a ride-sharing company. It was Lyft, to give seniors rides. And in a group of about 250 people, we asked, how many of you have heard of Uber or Lyft? How many hands do you think went up? These are kind of low to moderate income seniors in LA County.
time, maybe none of them.
Three.
Three hands went up.
Oh, see.
And
I always said three, it's my lucky number.
Good number.
So I asked each of them how they knew about it, and it was because they were part of the pilot. It was not part of anything. They had never heard of it before.
They were part of the pilot.
And so I think there's a huge digital divide, and I think it goes to a bigger problem of how we design health interventions, which is we design them around ourselves, and we think about ourselves, and ultimately a lot of the people who we're trying to serve are, to the previous point, not anything like ourselves or the people in this room.
No, Sachin, I'm so glad you brought that up, because we know, but we should state it, human-centered design is paramount in all that we do to formulate interventions. It's just the hallmark of great business, right? Start with knowing and understanding the needs of those you're serving.
But it's the diversity of the humans.
It is the diversity of the humans, and the problem is so prevalent among vulnerable populations, as I said, who are at much greater risk. So we need to start there. There are a lot of hands. So who can help us getting mics out to this terrific audience?
I think there's one.
They want to jump in.
There's a mic there.
I want to bring up that this is actually a part of human physiology that you're ignoring, because I used to work with Norman Cousins, and he would have an EKG technician
That's right.
that was unfriendly, could actually change the EKG in a person.
Yeah.
When you volunteer...
Or the MRI. The
Yeah.
MRI. Very different brain responses. Yeah, absolutely.
Absolutely. And when you volunteer with Red Cross, you change your amygdala. You actually
Right.
change your human physiology. So in our obesity program at UCLA, we have about half the people addicted to sugar. We have them helping each other. So I wanted to highlight the importance of
Yes.
self-help groups, not only in the clinical area where it improves efficiency with group intervention rather than doctor-patient,
Right.
but also Alcoholics Anonymous,
Sure.
Overeaters Anonymous, these kinds of groups. And we've always been scared about that as doctors, because we thought, that's out of control. But actually, when they find a sponsor and they find someone who helps them help themselves, this has been going on since the 1930s.
Sure.
It's something that I think we need to somehow relate to, so we feel friendly as physicians and public health officials getting people into those systems.
Well, on the
Yeah.
12-step programs, I'm a physician and I'm not scared. Here's why. When I was practicing, it was really the only thing. If we had we had a patient, I had a patient with either alcoholism, that was the only thing that worked. Or with weight control issues, it was Weight Watchers. And the common element of all of that is a shared community where you get up and you say something that in a sense makes you uncomfortable, but you tolerate the discomfort. Because what you get in return is a sense of connection.
Yeah.
And that's the only thing we can scale.
Yes.
We don't have enough
Yeah.
mental health professionals to run support groups around the country.
Sure.
But we can run support groups that are lay-led. Now, they need some facilitator training and they need some guidance and structure, and we're building that out. But our goal is to have those programs available in libraries,
That's
in
right.
schools, so that when you get in Lyft, you have someplace to go.
That's right. That's right. Well, you don't have a mic, but you've been waiting so patiently, and then I'll go back to you. Sir?
Brian.
Yeah. He's just been waiting since, and then I'm coming back to you.
Yeah, hi, my name is Brian Van Buren, and I'm a person living with Alzheimer's. I wanted to address the factor about the gay community, which I'm a part of. Isolation is a major factor within our community. And to give you an example as to why, in 1991, I had 28 people to dinner at my house. I'm the only person alive out of those people. The AIDS epidemic wiped out a large population. And so for many of us, we now live alone. We don't have partners. We don't have families. And it's killing us. Fortunately, I was an international flight attendant for 20 years. And I have to tell you, that's probably one of the most lonely jobs there are. For many people, they think it's glamorous. But after you've been to Paris 30 times, when you get to the hotel, you lock your door. You stay in bed, and then you get up the next day and come back home.
Right.
It wasn't until I got diagnosed with Alzheimer's that my life then became purposefully. The first thing I did, I stayed in bed for 3 months grieving. But then I got a card in the mail from this organization called AARP.
And you answered the call, right,
I answered the call. I started volunteering, and I was teaching a class on Life Reimagined.
Yes.
And I applied it to myself and realized that at some point in your life, you have two choices. You can either give up or you can move forward. And that allowed me to move forward.
Right.
So today, I'm probably the most happiest I have ever been in my life.
Wow.
Yes.
I'm a,
Thank you. And thank you for volunteering for us.
I'm a national speaker and I'm advocate, and for the first time in my life, I feel like I have a purpose.
Yeah. Thank you so much for sharing, Brian. And you underscore the point I made earlier that our survey, in fact, finds that LGBTQ elders have at least a 14% greater risk for social isolation and loneliness over time, meaning, as Lynn said, that interventions have to be specific for population groups. You have now waited so patiently.
Oh, no, thank you. My name is Phyllis Foxworth, and I'm with the Depression and Bipolar Support Alliance. You were asking about partnerships, and we have something called a senior initiative, and we've been funded by several foundations. One is the Archstone Foundation in California, where we're working with Providence St. Joseph in their FACey Mission Hills Medical Clinic, where their primary care physicians are identifying patients through their Medicare population, seniors who on a PHQ-9 identify with depression. And what we're doing then is providing them with peer specialists, trained and certified peer specialists, to go into their homes and do home visits with them to help them understand and develop wellness goals, thriving goals for themselves. And what they expect that the primary care physicians will discover is that, A, their PHQ-9 scores will go down, but also that their overall health will improve. And FACey is committed that to increase, once the foundation money runs out, that they're so convinced that they're going to find that their overall health care costs go down, that they're committed to continuing that program further. But also to address your other issue about support groups, DBSA has support over 600 support groups for people living with depression and bipolar disorder. So one of the objectives of the program as well is to start a senior support group meeting within the clinic, so people will be going exactly where they're getting their primary care, a place that they're comfortable with, and it's about meeting people where they're at.
Wonderful. That's really terrific. Time for a couple more questions. I'll let our colleagues help field them. Over here. Yeah.
So one of my concerns is that the schools are not having this type of conversation, and those youngsters are very easily identified. And I'm speaking from the knowledge of working with school districts. I am extraordinarily concerned that we have some of the answers, yet we're not addressing it. Very often when I do school trainings, one of the first questions I ask is, have you heard of the ACE study? No hands go up. So I'm just wondering, and there are pediatricians sitting up there, what's happening?
Maybe I'll make a comment. I have heard of the ACE study, and I think schools are critical. So I mentioned we're working with colleges around the country. So what's starting to happen is the traditional model in college health services has been a traditional medical model for decades. It was basically clinics on campus, so to provide like immediate care, and then if somebody was really sick, farmed them out into the local, kind of health delivery environment. That medical model has to give way, just like an advanced primary care, to a population health model. But they're in the schools are in transition. And the most encouraging thing I've been engaged with recently around colleges is last week I was in the engineering department of an Ivy League college was actually having, as many engineering, a human-centered design course. And the typical assignment is you pick a big challenge, and then you talk about human-centered design, which is a method, and then you assign the challenge, and then the students break up in teams and work on it. So the challenge for this last semester was what to do about loneliness on campus.
That's great.
And that's a student-led, student-initiated set of solutions. So I think if we're going to embrace population health, really, we have to ask the students what's going on with them. Otherwise, we'll just keep imposing a top-down medical model.
I mean, sure we do. In medical model, we don't want people to be seen as problems.
It's not wrong. It's just incomplete.
You're raising, I think, an important question, which is education at its earliest levels as well, which relates to teacher training, what's going on in the classrooms, and Lynn's point about building resilience and addressing from the earliest possible ages.
And it seems really the school health personnel focusing more on mental health issues broadly. Loneliness being one of them, bullying, stigmatization. There are a number of these issues that I think are at the root of many of the things. Even teen pregnancy has been associated with loneliness. And so, we see these things in kind of simplistic biomedical terms, but there's a lot more to it than that.
I think we have time for one more question. Vivian, you've been waiting over here. Oh, go.
Hi. Thank you so much. This is fantastic. And
Thank
my
you.
mom has also gone to classes at AARP, and it's been phenomenal in
Great.
terms of
Yay.
bringing engaging older people. So kudos to you. One of the
Thank
things,
you, Mom.
interestingly, my brother, meanwhile, he's not here, thankfully. He's 55, and he is incredibly lonely. And he has actually at least identified that he's lonely, and so he now, he joined a hockey team, and he's doing these different things.
Yeah.
But it's like, even though he's there, he doesn't know how to. He's gotten to the point where he doesn't know how to actually bridge that gap. So he's physically there, which is awesome. But when you talk about how to engage, like teaching people how to re-engage,
Right. So he's engaging now with a social network, but having some hesitancy to really connect with other people. Sachin, can you jump in on this?
Yeah, I mean, depersonalizing it from your brother for a second. I mean, I think one of the challenges is that loneliness is both a cause of depression, but also a result of depression, right? And so there's oftentimes other, I think, factors at play that really don't get identified. And when I hear your brother's story, I hear somebody who's, has some challenge actually connecting with someone. I wonder about, some of those factors. And I think we need to make sure we're thinking, very broadly, very holistically.
Yes.
This is not a, there's no silver bullet problem here,
That's right.
You can be part of a group and still feel alone. I think.
That's exactly it. And I would say, although it's not the total answer, because AARP Foundation, on our site we have a platform called Connect2Effect with an A.org that has many resources, tips, and tools for individuals and/or caregivers as well.
Just one quick thing, which is skill development matters.
It does.
You can teach people how to make friends.
How to have conversations.
Remember Dale Carnegie, How to Win Friends, Influence People? He had like 5 or 6 key rules. One of them, and with older adults, I mean, we all have older friends and relatives. There's so much pressure they have to tell their story.
Yes.
They're not really always great at listening. Listening is an active skill set. We need to teach that, right? That's part of have that electric circuit gets connected.
Yeah.
So obviously I don't want to personalize it to your brother, but I do know that there's skills that can be taught that facilitate an ability for authentic connection.
All right, we have to wrap up, so 10 seconds. Let's start with Lynn, and then we'll go to Anand. Anything you'd want to leave the group with? Final thought.
Yes, and what you said really reminded me of this, and it's why I'm so concerned about the children, because the primary time we develop those skills is when we're young, when we're very young. And if we are blocking the development of those social skills through too much screen time and too much time interacting with electronic devices, it may be impossible to teach those skills to an adult.
Yeah,
we
it
need
will grow
to
worse over time.
Developmentally, we're ready to learn language, we're ready to learn social connection when we're very young.
Thank you, Lynn. Anand.
I understand the Milken Institute's doing a project on the American dream. And if someone asks, well, what could put the American dream at risk, it could very well be if we don't pay enough attention to social isolation and loneliness. No one has ever attained the American dream on their own. They may have started with humble beginnings, but somebody has always provided a helping hand, and I think we need to make sure we provide a helping hand to others so they can attain the American dream and not be stymied by social isolation and loneliness.
Excellent. Sachin.
There's 100 people in this room. We can actually solve the loneliness problem of 100 people if each one of you actually commits to connecting to one person you care about in your life.
Right.
So call your grandmother.
No, that's absolutely right. Thank you. Practical advice. Jeremy.
Right, and then just building on that, own the challenge, own the opportunity, keep the conversation going. We don't really know the answer. We don't know how to measure it, scale it, sustain it, but we know it can be done and it needs to be done, and we have to do it.
Yeah. And I'll just wrap by saying thank you to my fabulous, extraordinary panel.